Hello and welcome to Voices of Wisdom, TIRO's podcast designed to share thyroid cancer pearls of wisdom from clinicians for clinicians. Think of it as a fireside chat where we'll be talking to international experts who will share their wisdom, offering practical advice to clinicians in a variety of common and sometimes complex clinical scenarios. I am your host, Dr. Janice Pasieka. I'm a surgical endocrinologist in Calgary, Alberta, Canada, and I'm excited to be your host of TIRO's Voices of Wisdom podcast. In addition to our other educational materials on thyroid cancer management that TIRO's been providing through our International Recommendations app and our weekly webinars. We hope these podcasts will complement our other educational activities by providing short, easily digested sound bites of clinical issues that we all face in the treatment of thyroid cancer. In each episode, I'll be joined by distinguished international guests who will bring their unique perspectives and expertise to the discussion. Today is our very first episode, and we're going to talk about a not infrequent problem, that of the rising thyroglobulin level in patients during post-treatment follow-up. I am thrilled to welcome our first guest, Dr. Michael Tuttle from Memorial Sloan Kettering, who brings invaluable insight into this area. So whether you're a surgeon, an endocrinologist, pathologist, medical oncologist, or a nuclear medicine specialist, these podcasts promise to be a pivotal resource in your quest for knowledge in the care of thyroid cancer patients. So let's get started. Let me first bring to the microphone Dr. Michael Tuttle. Mike, welcome.
Thanks very much, Janice.
Mike, we want to focus on that challenging issue of the rising thyroglobulin level in patients that undergo post-treatment follow-up. But before we get to that, maybe you could outline for us, what does thyroid cancer follow-up look like in your hands?
Yeah, I think that's a great start because there's a basic framework that I follow. The vast majority of the thyroid cancer patients, they get their surgery. They usually see the surgeon a week or two after surgery to have the path reviewed and their wound reviewed. And then they usually see me about 6 weeks after surgery, where we measure the thyroid function tests, the thyroglobulin antibodies, review their individual path report, determine what TSH goals are going to be, and really get that first look at that initial response to therapy. How are they doing? What did the surgeon find? What did the path report? What's the thyroglobulin? And then we plan the follow-up from there. For most of my folks, it's about every 6 months they come see me with blood tests for about 2 years. So that would be the sort of basic framework. We decide what the risks are, we decide our early plan, and then we adjust that as we go forward.
Is this something that can be done by the primary care physician, or would you recommend that all patients at least see a specialist in that first 2 years?
You know, I think you should see a specialist at least to start with. There are some patients that I see after surgery and they're so low risk, maybe they see me one more time. You know, they're kind of the exceptions. But I think the majority of patients, it's a complicated enough discussion to look at the operative report and the path report and the post-op TG that it's worthwhile at least seeing somebody to begin with. Most of my patients stay with me for a year or two before they go back to their local endocrinologist or regional folks if they're low risk and everything is going well.
And where's the role of ultrasound? Does that then become part of your follow-up going forward?
Yeah, it does. So when we have that first meeting 6 weeks after surgery, I'm looking at what's their risk of recurrence, what's the location of recurrence. Most people will get an ultrasound about a year after surgery if I'm not too worried about them. If they're more high risk with lots of lymph nodes or they were more worrisome to me, maybe I do a few more. But that first year or two, there will be 1 or 2 ultrasounds with timing based on the risk and what their TGs are doing and their risk factors from that standpoint.
Who do you follow more frequently or longer, or do you change from that sort of basic outline you gave us?
Yeah, I think that's really critical to know because that's the key to being, individualized medicine. So from a real practical standpoint, if I see somebody that had tons of lymph nodes in the neck, they're higher risk for having a recurrence in the neck. So I may do an ultrasound at 6 months and a year. If it's a patient that had vascular invasion or a poorly differentiated cancer that's more likely to have distant metastasis, well, then maybe 6 months or a year down the road, I do a CT scan of the neck and chest. Or it's a really aggressive anaplastic, I might do a PET scan and imaging at 2 months. So I think you can really rely on sort of the ATA risk stratification, where you'd be a little more intense, particularly in the high risk, and the higher stages would make you be a little bit more intense. But fortunately, I bet 90% of the patients that I see these days, because we're seeing such low risk disease, fall into that every 6 months, a couple of ultrasound that first 2 years, and a TSH of around 1 or thereabouts for most patients.
And does molecular testing sway you in any way? Like, do you get it on a routine basis? Does it make a difference to you?
Honestly, it doesn't sway me as much as what people think it might, because the molecular testing cases that worry me already have other bad features. They're invading the windpipe. They've got lots of lymph nodes. They've got distant mets. So as an independent factor, not really. And I'd be lying if I didn't tell you I'd worry about somebody that was BRAF plus TERT or RAS plus TERT. Yeah, I'm going to worry about them a little bit more. So maybe it flavors my follow-up a little bit, but not a lot, independent of everything else we know from the operative findings, the pathway findings, the TG, the ongoing follow-up. So I'd say it colors what I do, but it's not a major discriminator in terms of how I do things.
So from an international perspective, because not all places can get molecular testing easily, you're not critical if you do not have molecular testing following these patients.
No, not only am I not critical, I'm very supportive of that. The vast majority of patients that we follow after their thyroid surgery, we don't do molecular testing on them at all. I reserve those for the higher risk one, the distant metastasis. I recognize that the molecular stuff can give you some subtleties in terms of risk stratification. But to my mind, it doesn't really add much beyond the ATA and the AJC system. So no, I would not want to see everybody getting fancy molecular testing on every thyroid cancer that comes out. That's just not a good use of our healthcare dollars.
Yeah, that's great, Mike. Well, let's put it, let our listeners bring it into like a clinical scenario here. So you have, let's say, a 48-year-old female patient. She was intermediate risk, well-differentiated thyroid cancer, 3 centimeter papillary with some vascular invasion, and 5 out of the 9 lymph nodes recovered from her central compartment were positive, all small, microscopic. She had a total thyroidectomy, obviously a central lymph node dissection, and this was followed by I-131 remnant ablation. How do you approach this patient? So this patient is coming to you already undergone some treatment, but wants to see how the experts do it. This is what was done at our local institution.
Sure. And a very common presentation and a very common surgery and path report radioactive iodine. So we get this consult a lot when people come in. So the first thing in my head is back to risk stratification. What's the risk of recurrence? What's the likelihood of distant recurrence? And then secondary is what's her response to therapy? How has it worked so far? So I'll look at the age of the patients. The younger patients tend to have a higher recurrence. The older patients, a higher recurrence, and this middle age more in the middle. You already told me she was intermediate risk, so I'm going to have to be watching for some lymph nodes in the neck. 3 centimeter papillary is pretty good size. They often have lymph node metastasis, so I worry about lymph node number 10. You told me you took out 9. I'm a little worried number 10 might be there. The vascular invasion makes me worry about distant metastasis. So this is somebody I'm going to have to think about more than just the neck on a papillary cancer. If it's had access to the bloodstream, there's a chance she could have distant metastasis. So I would look at sort of where we are with the thyroglobulin. A lot of times this consult is 3 or 4 months after they've been treated. So I would measure thyroglobulin, antibody, TSH, likely do an ultrasound if we've never done one at our center to make sure that we really have addressed all their lymph nodes, and then re-stratify from there.
And thyroglobulin antibodies, sort of the bane of the endocrinologist existence?
They are. They make our job much harder, because if those thyroglobulin antibodies are present, you can't trust the thyroglobulin. It often causes falsely low thyroglobulin. And this patient's a perfect example where the antibodies would really bother me because of that vascular invasion. If there's no vascular invasion and they have antibodies, well, the recurrence is going to be in the neck. I'm going to find it on the ultrasound, no big deal. But in follicular thyroid cancers with vascular invasion, Hürthle cell cancers, not being able to rely on that thyroglobulin to tell you there's no distant metastasis means you will do more cross-sectional imaging of chest CTs and that sort of stuff, because you can't be comfortable that you're not missing something out there in the distant world, at least for the first year or two. So the presence of those antibodies does change the follow-up that I do, because I just have to remember something could be brewing and me not see it in the thyroglobulin. Now, that being said, there's some really good information that shows if that thyroglobulin antibody decreases about 50% that first year, that's a really good sign and very unlikely that you're missing anything. Carol Spencer showed that years ago, and it's absolutely right. That thyroglobulin, if it was 200 before surgery and by 6 months we're down more than 50%, great sign, we're probably not going to miss anything. And then those thyroglobulin antibodies generally gradually go down over 3 to 5 years. So that first 50% decline is a really good one to hang your hat on that says you're probably not missing anything.
What percentage of the patients do you see have thyroglobulin antibodies? Is it a big percentage or small?
So if you look at everybody that walks in the door, it's around 25%. Now, most of those are relatively low level. And a lot of times by 6 months, the antibodies have resolved or they're markedly lower. And that's been fairly consistent over the last 20 or 30 years. It's around 25% of the patients that those antibodies will be real, which is why it's important to never measure a thyroglobulin alone. Measure the thyroglobulin and always measure the antibodies. Even if the patient has had negative antibodies for 5 years, sometimes the first sign of recurrence is a change in that antibody. So anytime, no matter where you are in the course of that disease, resist the urge to check off thyroglobulin alone, thyroglobulin and antibodies every time.
So let's say you follow this patient, the thyroglobulin and the antibodies, serial head and neck ultrasounds, and everything remains stable. And the thyroglobulin and antibodies are undetectable for the first 3 years. Then on year 4, the patient comes back and now has a detectable thyroglobulin level. 2.4, not super high, but detectable. Now what?
So when you think about that, that's in the right time frame to see a recurrence. So you showed an intermediate risk papillary, a few little lymph nodes. If you look at when we'll often see their recurrence, it's 3 to 5 years down the road. So you've given me a thyroglobulin in that 4-year window. So that's a time it could be real. The first thing I do is I repeat it because sometimes it's just wrong. And this patient is at, by this point, relatively low risk of recurrence because we're 4 years down the road. So repeat it, make sure it's real. And if it's real, when the thyroglobulin is less than 10 in the neck, look at the neck. It's going to be a little small lymph node in the neck, the overwhelming odds are. Now, in this one we started with, there was that vascular invasion, so we got to keep that in the back of our mind. But if you look at all the studies, the level of the thyroglobulin in lung mets is more like 20, 50, 100. So in this 1 to 2 range, we're probably missing a little small persistent lymph node met, number 10 that I told you about a few minutes ago. It's not new, it's been there, slow growing for 4 years. So I'd be focusing on the neck to see where that thyroglobulin is coming from, likely in a small little lymph node, less likely in the thyroid bed where you did the surgery.
So you start with an ultrasound, and when do you escalate it beyond an ultrasound and go to cross-sectional imaging?
So somewhere around a thyroglobulin of 2 or 3, in that ballpark. Because a lot of times if you're using the assays that we use that have thyroglobulins down to like 0.1, you don't see it go from undetectable to 2. You see it go from 0.1 to 0.5 to 0.9, and you're not really sure. So you've done a few ultrasounds over time is typically how that works. If somebody's seeing me for the first time in this scenario with a TG at 2.4, I start with the ultrasound because that's the best way to find little teeny lymph nodes that are not ready for surgery, not ready to do anything, but the ultrasound can detect abnormalities in normal sized lymph nodes. If I don't see anything there, I actually do a CT scan of the neck and the chest. Not so much because I'm worried about disease in the chest, but those lymph nodes in the low neck can be in the upper mediastinum. The CT scan sees lymph nodes laterally, it sees retropharyngeal. So I'm really still looking at the neck, but that best view of the neck is with a CT scan of the neck and chest. That would be the start.
And that's an infused CT scan, and it's not a PET scan. I think that's important to bring out.
Yeah, so it's a CT with contrast because we got to be able to see the neck and the lymph nodes. When you have these low-level thyroglobulins like this in a papillary thyroid cancer, this has taken 4 years to grow back. It's not using much sugar. That's not the stuff that FDG PET scan finds. So I would start just looking in the neck. I will tell the patient with a TG at 2.4, I'm probably not going to find it. It's going to be some little small lymph node that may look normal to me or may look a little bit atypical. So I set that expectation that we may need to do ultrasounds and CTs flipping back and forth for a year and a half before I can find where this little lymph node is that needs to be taken care of. So they all want me to find it yesterday, but oftentimes I can't find it till the TG is 5 or 7 or 10. So I set that expectation. We're not missing anything big. We're looking for something small, but it may take us a little bit to find where that little small place is.
And Mike, when do you involve the surgeon? Because, as a surgeon, we get asked to see little tiny ditzels in the neck, and we're kind of going, yeah, we could go in there, but are we really changing the course of this patient's disease? by taking out a 9 millimeter or a 1.2 centimeter lymph node? When do you get your surgeons involved?
Yeah, it's a great question. We've developed language for this. We talk to the patients about what's detectable and what's actionable. Our tools are so good with ultrasound and CT and PET, we can find stuff that surgeons have a really hard time finding, right? So we talk about what's detectable and what's actionable. And then I tell the patients when I detect something, and we use the term detectable findings, not detectable disease, so you don't have to biopsy something, but detectable findings. And the 5 things that we use is what's the size, what's the location, how rapidly is it changing, is it going to cause any symptoms, and then the 5th one is patient preference. As soon as I can find anything, I do involve the surgeon, but I do tell the patients that I usually say, I'm the most aggressive surgeon at Memorial because I don't have to do the surgery and I'm not the patient, right? So I can be really aggressive. But I do tell them I can find things that I think the surgeons would have a hard time finding, or honestly, I think may hurt them more than it would help them by doing that. So I set that stage to get you guys involved, hopefully before you need to operate. And then you follow with me and help me understand, because it's the location piece a lot of times I don't understand that surgeons really do, right? Is it near a nerve? Is it near a trachea? And then the other thing I tell the patients is I tell them I'll ask the surgeon if it got 25% bigger, and they never really do that, but if they did, would it grow into anything important and would it make your surgery harder? And if the answer to either one of those is yes, that's going to lean us towards surgery. But if the surgeon says, no, it's not going to hit anything right there, be hard to find right now, then we may watch.
And you say that you're watching, so you're not pulling the trigger of let's give more radioactive iodine. Is that a thing of the past? Because that used to seem to be the standard. Okay, there it is. Let's blast it.
Yeah, that was the standard. And if you remember, the standard went through, we found it, and then we would force our surgeons to operate. And then finally, you guys said enough. And then we go, well, we have to do something. So then we went with radioactive iodine. And then we realized the vast majority of the time that doesn't work. I mean, this is persistent disease. She had radioactive iodine on day 1. Whatever this is has lived through that dose of radioactive iodine. Now, if I find lots of little places in the neck or something that's going to be a challenge to surgery, sometimes I will do a radioactive iodine scan, the diagnostic scan, just to prove that it's negative. And rarely I'm surprised, and it does grab onto radioactive iodine. So sometimes before surgery, we will do a diagnostic scan so that we kind of close that door. But no, we don't routinely just give another dose of radioactive iodine at this point.
And we talked a little bit, you sort of indicated that your thyroglobulin levels, once they get above 10, is when you start looking outside the neck. Is that the trigger of when you start bringing in PET? Do you follow that? Do you follow them at 10 and look for the cadence of it? Does that help you?
Yeah, absolutely, Janice. So I look at how rapidly the thyroglobulin is rising, right? Is it doubling every 6 months or is it doubling every 20 years? That's different. I also look at the tumor, like tall cell variants tend not to make thyroglobulin as well. So I may pull the trigger for CT scans and PET scans closer to 5 on kind of a high-risk tall cell variant or a poorly differentiated one, as opposed to a kid with a classic papillary that always makes tons of thyroglobulin. So I do flavor in there a little bit about the histology. But if it's keep going up, because these things hardly ever double more than yearly. So by the time you're from 2 up to about 7 or 8, you're a couple years down the road. You've got a bunch of CT scans that haven't found anything. You've got ultrasounds. Then looking above the ears with CT scans to make sure you're not missing something in the brain or the skull, looking for PET scan. So you hardly ever get down that pathway, but when you do, when it's up there, then I tend to flip back and forth between imaging modalities every 6 months until I can find the localization. So if you hang a hat around 10, that's probably a good thing, as a reasonable thing to begin thinking about when to do other studies outside the neck.
As a surgeon, we spend a lot of time saying, yes, we can technically go after, now we can see lateral neck. It's a virgin territory. Yep, we can then clear that. But we're just resetting the clock, are we not? Is there still this perception this can be cured?
Yeah, I still say with some of my surgery friends who are the most aggressive, I will tell my patients they're under the mistaken impression they can cure them. So they will take out 1 million little lymph nodes. Now, that being said, about 10 or 20% of the time when you do a surgery, you can make the thyroglobulin go away. So it's not zero. Now, you let me follow that patient for another 5 or 10 years and it'll be back. So you can reset the clock, as you said. So I tell the patient, the goal is not to change the thyroglobulin number. If it goes down, that's cool, but nobody ever got hurt by a thyroglobulin. The goal is to prevent the disease from hurting them. So the purpose of surgery is taking out disease that I think would hurt them, taking out disease that would be more difficult to operate on. So I try to be clear with the patients. The goal of the surgery is removing the cancer for a good reason. Most of the time the thyroglobulin goes down, but sometimes it doesn't. Even if the thyroglobulin doesn't go down, I'm still happy with that surgery because we took it out for some structural reason. That needed to be treated. There may be still some other place I need to look at. So oftentimes, Dr. Shaw in the front row of our head and neck surgery, his favorite question is, what's the goal of your surgery? What are you trying to accomplish? Please don't tell me you're trying to make a thyroglobulin go from 2 to 1. That doesn't sound like a good goal of surgery, right? So if you have to answer what's the goal of the surgery, then it gets you to that harder question, like, should I operate or should I not? And really question some of our standard paradigms about always operating if we see something. Right?
That's been really helpful, Mike. I think, if we had to summarize, following thyroglobulin and the antibodies is a very helpful tool. But I'm getting the sense it's not hit the panic button as soon as you see something move.
That's absolutely key because it's so unusual to see rapid growing thyroid cancer, right? This is almost always slow growing for the things that we deal with. So most of the time I tell the patients, maybe a little bit of a change, ask me again in 6 months. I'm not ignoring it. We'll look at it. We'll do the appropriate testing. And the other part of it is, even if it takes 5 years to grow back one little lymph node, if you watch for another year, you may find a couple more little lymph nodes. And now you can do a second surgery just one time, as opposed to plucking out one and then 3 years doing the same thing. So patients hate it when I say sometimes I need to let the weeds in the garden grow. They really don't like that sentence. But in my heart as a farm boy, sometimes you got to let the weeds in the garden grow before it's time to intervene and do anything.
What advice would you give our listeners from watching a rising thyroglobulin? What do you give us a couple of words to summarize it?
So I would say when you have that rising thyroglobulin, if you're not doing a lot of thyroid cancer, it may be time to get a second opinion to prevent either overtreatment or undertreatment. Now, if it's rising from 0.1 to 0.2, I'm not going to lose my mind. But if it's constantly marching up and you're not seeing it on ultrasonography, then sometimes you need the high resolution ultrasound at a big thyroid center. We know where to look. But I think the real key is not to get too excited. Recognize it's persistent disease. It took 4 or 5 years to get on the radar screen. Patients still don't like it back, but they find it reassuring that it took 4 years to grow. This didn't happen last week. If it took 4 years to grow, it's going to take me a little bit to find it. So I think explaining it in the context of persistent rather than a recurrent disease, and in the context is this is almost certainly going to be treatable when it's time, and just be frank with them and tell them one of our hardest decisions is when it's going to be time to treat. We're going to be able to find something, and then we're going to do a lot of talking about when it's time to intervene versus when it's time to watch.
That's great, Mike. I think that's been a very informative discussion on this not infrequent problem. Now, before we wrap things up, I thought we should end with a little extra knowledge for our listeners, something that goes beyond medicine. You've been living and working in New York City for many years now. So what advice would you give me as to the one thing I should do or see if I was visiting New York City? In other words, what's the hidden gem for us people foreign to your wonderful city?
That's an absolutely fair question. So I'll tell you the two things I send people to do all the time. One is the Staten Island Ferry. The Staten Island Ferry departs from the very southern tip of Manhattan near Battery Park. The most important part is it's free. And on the trip to Staten Island, you can see the Statue of Liberty. Look at it on the way then, turn around and come back. It's easier and cheaper than standing in line to pay for the fancy thing. So if you want to take the kids on a quick, here's what the Statue of Liberty looks like. And when you're coming back in from Staten Island, you get to see New York Harbor and the whole skyline. And then the second thing we love to do is the Bronx Zoo. It's about a 45-minute subway ride away from Times Square. But the Bronx Zoo in the middle of the Bronx is the most incredible zoo you've ever seen. So Staten Island Ferry for free if you're on Manhattan. And if you want to be a little adventuresome, Bronx Zoo, and say hi to me and my grandkids when we're up there.
Fantastic. Well, thank you. That brings us to the end of our first podcast, Voices of Wisdom. I'm Dr. Janice Pasieka, and it has been an absolute pleasure to host today's discussion on rising thyroglobulin levels. I want to extend a special thank you to our guest, Dr. Michael Tuttle, for his invaluable pearls of wisdom. If you have any questions or suggestions about future podcasts, email us at voicesofwisdompodcast@gmail.com. Stay tuned for future episodes, which will include the treatment of well-differentiated thyroid cancer in pregnancy, active surveillance, the role of I-131 treatment in intermediate risk cancers, and more discussions like that. If you liked our podcast, please subscribe to our webinars, which air live every Friday morning, 8 a.m. Eastern Time. This series is for thyroid clinicians and researchers that covers breakthroughs in thyroid cancer research and treatment in the form of topical journal clubs, state-of-the-art lectures, international multidisciplinary tumor boards, and live panel discussions. Just visit tyro.expert/subscribe or click on the link in the description. I want to thank you all for joining us today, and I want to leave you now with a quote from one of the great diagnosticians and one of my heroes, Sir William Osler, who in 1885 said, "Clinical judgment comes through experience. We must know the natural course and tendencies of a disease to be able to estimate the importance of complications and indications of special symptoms that may arise. Every year of careful studies will strengthen your powers and add to your prognostic skills." So keep that in mind. Every patient you encounter in the coming weeks will add to your understanding of thyroid cancer. And with that, I wish you all a pleasant day. Keep smiling.